So let's talk a little bit about the route of lymph flow. So as we already talked about quite a bit when it comes to capillary hydrostatic pressure versus capillary osmotic pressure, you're going to get, ideally, if you're healthy and you don't have any protein deficiency, ideally your capillary hydrostatic pressure is going to outweigh capillary osmotic pressure, meaning that you're going to have a net filtration of fluids. And the net filtration of fluids is going to eventually accumulate within the interstitial space where you find interstitial fluid. And then that fluid eventually makes its way into the lymphatic system. So the lymphatic system is going to be what collects all that extra fluids, and it's going to be collected through lymphatic capillaries, which eventually migrates or turns into your lymphatic duct system. And so in terms of lymphatic capillaries, those are where you're going to see the collection of lymph, and then you're going to have vessels that are going to connect to lymph nodes, which kind of act as like filtration systems to filter out or to try to identify things that might be pathological or pathogenic, like viruses, bacteria, etc. And then eventually the fluid is going to make its way back into the cardiovascular system. Now, the main flow of lymph is going to be through the lymphatic trunk. You're also going to see flow on the right side of the body flowing into the right subclavian vein. I'm going to show you what that looks like in a second on an image. And it's a very important image for you to conceptualize. But the majority of lymph, I would say about 3/4 of all your lymph, 75%, is going to be drained through lymphatic trunks. There's going to be 6 different collecting ducts, and then there's also going to be lymphatic drainage into the subclavian vein. So subclavian, meaning below the clavicle. You have 2 different subclavian veins, and that's where you're going to get drainage back into the cardiovascular system, back into your major vessels. So there's your lymphatic trunks, and then your subclavian vein. Those are going to be the most important. Now, the thing to keep in mind about lymph flow is that it's actually going to be happening really slowly compared to your blood flow. Blood flow is going to happen a little bit more rapid, but lymph flow is going to be really slow. Lymph flow is also going to be slow because it's important for your immune system to actually be able to identify potential pathogenic organisms within your lymph. And so that if you do have like bacteria, for instance, or viruses, that's where your immune system is going to start detecting the presence of those infectious agents. So definitely know this chart over here. This is going to be the regions that you'll see lymph flowing from and then to. So the majority of your body, about 3/4 of your body, from your left side of the trunk and head all the way down to your lower appendages, that's all going to be flowing in through the thoracic duct. So let me go to that. So the thoracic duct is going to be one of the major entryways from the lymphatic system throughout the body. However, the upper right portion of your body, so that's going to be upper extremity, as well as the right side of your thorax, plus the right side of your head and neck, those are going to be draining into the right subclavian vein. That's going to be the right lymphatic duct system. So make sure you know that. The interesting thing about the lymphatic system is that it's kind of similar to the venous system insofar as it has a unidirectional flow. So it's going to be moving in one direction, and that's going to be aided with the presence of aided by the presence of valves. And I'm going to show you what that looks like in a second. But in order for lymph to be able to accumulate within the lymphatic system, it's going to be entering in through these lymphatic capillaries. And you're going to find lymphatic capillaries throughout the body, with the exception of these areas. You're not going to find them in bones, you're not going to find them in bone marrow, and you're not going to find them in your teeth. Okay? Another thing to keep in mind is that these systems are extremely permeable. Fluids are going to be able to enter in there at ease. Let's talk about the valve system real quick. So the valve system, because lymph is going to be flowing not only really slowly, but it's also going to be flowing at very, very low pressures. There's not really much like gearing or guiding the flow of lymph aside from, similar to the venous system, your skeletal muscle contractions. Whenever you contract your muscles, not only is it going to help move deoxygenated blood through your venous system back to the heart, it's also going to help to move lymph throughout the lymphatic system as well. And then other things that can help to increase the flow of lymph will be like exercise. Exercise, you're moving a lot of your skeletal muscles, and that really helps to move lymph along that unidirectional way through those valvular systems. So, to reiterate, very low pressure and very low in terms of its speed. And it's also going to be aided by skeletal muscles. So it's very similar to what you see in the venous system. The venous system is going to be a little bit more rapid. The lymph is going to be kind of similar in terms of the way it flows. And then the subclavian veins are going to be some of the major collecting points for lymph to enter back into the venous system. So both right and left subclavian veins. The right subclavian vein from the right upper body. So just remember, just keep that in mind. Now, you're going to find lymphatics throughout your body, right, except for bones, bone marrow, and teeth. When you find lymphatics in your GI tract, they're going to be in the form of lacteals. And lacteals are going to be playing a role of collecting fat from your diet. So whenever you're absorbing lipids in through your small intestines, that's going to be carried through the lacteal system. Let's talk about some other lymphatic tissues. So we talked about lacteals. Some other types of tissues that you might find within the GI tract would be things like Peyer's patches. Peyer's patches are going to be associated with mucosal associated lymphoid tissue. So that's MALTs. We're going to talk about those in a second. So that's going to be inside your GI tract. In other words, these are going to be predominantly playing the role of detecting pathogens from whatever you consume. And within your Peyer's patches, I'm going to show you a picture of what that looks like, but you're going to have like dendritic cells, for instance. Dendritic cells are going to have little tiny finger-like appendages that kind of scour the environment, looking for antigens. And if one of those antigens is indeed pathogenic, then it's going to take that antigen and it's going to present it to T cells to help mount a immunological reaction. So we're going to talk about that especially during part 2. You're also going to find lymph nodules that are aggregated, that are unencapsulated, versus lymphatic organs. So if you talk about a lymphatic organ, that's generally going to be an encapsulated organ. So one good example of that would be the spleen. The spleen does a lot of things, but one of the things it does, it has a role in the lymphatic system. Also, lymph nodes are going to be encapsulated. And you're going to find these in different areas. So thymus, lymph nodes, tonsils, spleen, red bone marrow. Those are going to be considered lymphatic organs because they're going to be not only producing lymphocytes, but they're also going to aid in the maturation of different types of lymphocytes. For instance, in your thymus, that's where T cells, when they go to migrate, they migrate to your thymus, and when you have release of thymosin, and things like that, that's going to help to mature those T cells so they can go off and do their work. Here's another image of what that looks like. We have lymph nodes. Those are going to be considered lymphatic organs, right? So they're going to be actually encapsulated. And those lymph nodes are going to serve multiple different functions. For instance, it's going to have lymphocytes in there. It's going to have macrophages that are going to be able to actually gobble up and phagocytose any sort of infectious agents. So let's move on here. So in terms of lymphatic organs, those are going to be encapsulated. So you have a couple different types. You have primary lymphatic organs and you have secondary lymphatic organs. Primary, that's basically where these lymphocytes are going to be produced, and it's going to be where they're going to be able to mature. So when you think bone marrow, I want you guys to think B cell lymphocytes. And then when you think thymus, I want you to think T cell lymphocytes. So it's pretty easy because bone marrow, B cells, thymus, T cells. And then secondary lymphatic organs are going to be basically where B cells and T cells are able to start being able to recognize pathogens that are out in the environment. So lymph nodes, you have a ton of them. You have cervical lymph nodes, you have axillary lymph nodes underneath your armpits, you have inguinal lymph nodes. You have lymph nodes found in many different regions in your body. And then your tonsils, that's what you find within your oral cavity. We have palatine tonsils, you have lingual tonsils, and we're going to talk about those in a second. And then your spleen. If you recall, when we talked about red blood cells, your spleen is going to be performing multiple functions, including clearing out old, defective red blood cells. That's going to be one of the things it does. But your spleen is also going to be playing a role in your immune system as well. So it does a lot of different things. It's not just sequestering red blood cells to recycle heme, for instance. So, lymph nodes. Lymph nodes are going to be found along lymphatic vessels. So whenever you have lymph getting transported into those lymphatic capillaries eventually start becoming larger, and they become lymphatic vessels. And basically what a lymph node does, it acts as a filter of sorts. So lymph is going to travel through those vessels. It's going to have to pass through a lymph node. And once it passes through the lymph node, it acts as a filter. So you're going to have all sorts of leukocytes in there, like macrophages, as well as B and T cell lymphocytes that are going to be able to detect different pathogens. One thing to keep in mind about the way lymph is going to be flowing through these lymph nodes, you're going to have multiple different entry points into a lymph node, and then you're going to have just a couple out points from that lymph node. So in other words, you have a greater amount of fluids entering in, and then because you only have one or two out points from that lymph node, it's going to help slow down the actual velocity of lymph. So it travels slower through the lymph node. That's how it helps acting as a filtering mechanism. You're going to have macrophages in there, and you're going to have lymphocytes, B cells and T cell lymphocytes. So here's another schematic of what a lymph node looks like. Just take note that this is the entry point. So that's going to be your afferent system. Afferent, think like your point of entry. Think A in the letter as the first letter of the alphabet. That's where you begin. So afferent, and then all the lymph is going to cycle through inside the lymph node. You're going to have trabeculae, which are going to be just ridges that subdivide different areas of the lymph node. And then as the afferent lymph is going to be entering those afferent vessels, eventually it's going to make its way out through the efferent vessels. Efferent, think exit, okay? So afferent coming in, efferent coming out, exit. So you are going to see a dense fibrous capsule around these, because if you think about lymphatic organs, those are going to have fibrous capsules on the outside. And then you're going to see the cortex, that's going to be the outside, and then you're going to have the medulla. So it's very similar to your adrenals. Think adrenal cortex, adrenal medulla, whatever's on the outside versus whatever's on the inside. And then you're going to have two efferent vessels. That's going to predominantly help in increasing the amount of pressure that the fluid has to go against. So it's going to force fluid to basically linger within the actual lymph node itself. And just note that there's going to be lots of macrophages, T cells, B cell lymphocytes. So lymphadenopathy. Lymphadenopathy, this would be considered cervical lymphadenopathy. That can happen due to multiple reasons. Maybe the patient has, mono. Maybe they have infectious mononucleosis. Maybe they have another type of respiratory virus, or maybe they have bacterial infection. If the lymph from the region that's affected travels down through the cervical lymph nodes, those lymph nodes get enlarged, and now you have cervical lymphadenopathy. Not to be considered with lymphedema. Remember when I showed you those images of those folks with like really enormous legs, or maybe women who had radical mastectomies, they had enlargement and edema of their arms? That's called lymphedema, not to be confused with lymphadenopathy. You have lymphadenopathy, that's just swelling of your lymph nodes. And you have multiple different areas. You have your anterior and posterior cervical lymph nodes. There's several lymph nodes that course along those areas. And don't worry about some of these like submental versus preauricular, tonsillar. There's going to be lots of different lymph nodes that would indicate different areas that might have infections. but you're not really responsible for knowing which lymph node specifically would be affected. With the exception of the mammary and axillary lymph nodes. Now, this is one exception. You really should know this. Whenever a patient has breast cancer, when you test for breast cancer, of course, you can do like mammographies, where it's basically an x-ray to see if you have any sort of abnormal breast tissue. You can also palpate whenever you do a physical exam on a patient. You basically kind of like have the patient lift their arm and you put your fingers up there gently, because sometimes they might have ulcerations in that region, so you gotta be careful. But you're trying to palpate for any sort of abnormal swelling. Those would be your axillary lymph nodes. That would be like the number one indication that the person has breast cancer. And at that point, if their axillary lymph nodes are indeed enlarged, that would be considered stage 3 breast cancer. That means that local lymph nodes are being infiltrated, and then once you start going beyond that and start affecting other organs, then that would become stage 4 cancer. I'm going to show you what that looks like in a moment. By the way, would the left breast go to the, I guess, where would the left breast lymph go towards? What would be like the final destination for that, aside from like the subclavian? Remember that image that I told you guys need to know? That would go towards the thoracic ducts. Okay, so left side of the body, left side of the thorax would go into the thoracic ducts. The right side of the breast, so the right breast would go into the axillary, and then it would make its way towards the right subclavian. Okay. So here's a side note on cancer and like cancer staging. You guys, I'm sure you guys heard of like terminal cancer, stage 4 cancer. That just means that at the point you get to stage 4, that's where you have actual metastasis to other organ systems. Now, with stage 1, that means you have irregular cells. Those cells have not necessarily begun invading into tissues. Stage 1, usually, not a lot of times it's going to be asymptomatic. The patient doesn't even know that they have cancer at that point, because stage 1 hasn't actually caused any sort of tissue damage. It hasn't necessarily obstructed any lymphatic systems, etc. Stage 2, that's when you actually start getting invasion of tissues. So stage 2 tumors are going to start invading into tissues. Once you get to stage 3, that's when you actually start getting lymphatic involvement. That's when that cancer is starting to affect those adjacent lymph nodes. Adjacent meaning next to whatever tissue is being affected. Then, once you get to stage 4 cancer, at that point, it's metastasized. It's gone to other parts of the body. And oftentimes, it's going to be traveling through the lymphatic system. So let's talk about the tonsils real quick. The tonsils are kind of interesting. There's going to be 4 different sets of tonsils. The major one that we think about, that's going to be the palatine tonsil. So whenever a doctor or a nurse, they put a tongue depressor in your mouth and they have you go, ah, right? That's going to be your palatine tonsils. They're looking for those. There's going to be on like the lateral sides of your mouth, just right here on the sides, lateral. So that's going to be the palatine tonsils. Those are often going to be the ones that are like first infected. If a person, for instance, has like strep pyogenes, Streptococcus pyogenes, which number 1 causes strep throat, those are going to be the tonsils that are mostly affected. Lingual tonsils, lingual meaning tongue, those are going to be at the back of the tongue. Pharyngeal tonsils, those are also going to be referred to as adenoids. Those are going to be on the back of the nasopharynx. So it's behind, posterior to the nose, and it's where the nose basically connects to the oral cavity. And then tubal tonsils. These ones are kind of interesting. Tubal tonsils are going to be associated with the eustachian tube. The eustachian tube is where you have the connection from your ears into your mouth. That's why the ears are going to be sort of considered part of the upper respiratory tract. It's because the ears are eventually going to connect to the larynx and pharynx through the eustachian tube. So if a patient, for instance, has otitis media, it's affecting their ears, that's going to be considered part of the upper respiratory tract. That's considered a URI, an upper respiratory tract infection. And so think of tubal tonsils as being associated with that. And then these are other images of what that look like. These are going to be your palatine tonsils. That's what you look at when a patient opens their mouth and says, ah. The adenoids you wouldn't be able to see, right, because those are going to be part of the nasopharynx. So this is where you'd see like the uvula, for instance, right here. You wouldn't be able to see above that. You would have to use like a special type of scope to be able to visualize that. And then lingual tonsils are just going to be on the very back of the tongue. So this is what it looks like when you have normal palatine tonsils, and that's what your palatine tonsils look like when you have Streptococcus pyogenes. Pyo means pus forming. That's why Streptococcus pyogenes is called strep pyogenes. It forms a lot of pus. It doesn't just affect your throat. This can also cause necrotizing fasciitis. It can cause scarlet fever, rheumatic heart fever. It can cause glomerulonephritis affecting your kidneys. Strep pyogenes is a really aggressive and super nasty bacteria, but when it's just like a localized infection and affects your throat, sore throat, this is what you're seeing. It's mostly going to be due to strep pyogenes. What's up? Huh? Yeah. Well, if it's due to a virus, when we talk about strep, we're talking about streptococcus. So that's the genus of bacteria. If it's a viral infection, we wouldn't call that strep throat. Yeah, strep throat is specifically pertaining to streptococcus organisms. But viral infections are also pretty common when they affect the tonsils as well. Pretty common to get sore throat from a virus, but it's not going to be called strep throat because strep throat specifically is bacterial. What's up? Yeah, they'd be removing the palatine tonsils. And that's why I included this article right here, Geisen. Geisen wrote this article talking about different conditions that would indicate, like indications for tonsillectomies, so removal of the tonsils. So reoccurrent tonsillitis as a consequence of just getting like sick all the time, and it starts like causing irritation, obstruction. That's maybe it's like making it really hard for you to eat and just activities of daily living, things like that. It wouldn't be activities of daily living, really. It would just be more just like irritation, just like constantly affecting your throat. You can also get tonsillectomies just if you have sleep apnea. So that's like obstructive type sleep where basically you don't get proper amounts of sleep. Sometimes it has to do with your tonsils. Abscesses might be indications for tonsillectomies, pharyngitis, adenitis, a lot of different indications, but most commonly it's going to be you have these recurring episodes of tonsillitis just due to different types of infectious agents. Let's talk about the spleen. So the spleen, as I mentioned, it serves multiple different functions. It's going to be helping to clear out red blood cells. It helps to like basically recycle heme from dead and damaged RBCs, but it's also going to have lymphatic capabilities as well. So let's talk about the anatomy of it real quick. It's going to be found on the left side of the peritoneal cavity. It's going to be sort of in the left hypochondriac region, so left upper quadrant of the GI. It's going to be sequestering those red blood cells. It helps to recycle heme, and it does produce erythrocytes during fetal development. As a matter of fact, there's some animals that don't really have bone marrow. One good example would be like salamanders. They don't really have bone marrow. They rely on the spleen for their hematopoiesis, as well as a little bit of their liver too. You're gonna find large collections of macrophages as well. The macrophages are going to help to phagocytose any sort of infectious agents or debris. Splenectomies. So let's talk about splenectomies real quick. There's a lot of conditions that might require splenectomy, especially if you had splenic rupture. I had a friend, for instance, he got into a car accident and it ruptured his spleen. The spleen is very highly vascularized, and generally speaking, if you have splenic rupture, you want to remove that surgically. Otherwise, the patient just bleeds out internally. So that's a huge issue. Patients can also experience what we call autosplenectomy. That would be a consequence of, for instance, sickle cell disease. When a patient is sickling, their blood cells all of a sudden become malformed. They undergo a sickling crisis. Those red blood cells start getting trapped into the spleen. Over time, you start getting so many damaged red blood cells in the spleen that eventually you start getting necrosis of the spleen, and the spleen just basically dies on its own. They call that autosplenectomy. If you do get your spleen removed, it's not the end of the world. The biggest concern with splenectomies is that you might be predisposed now to getting encapsulated bacterial infections. So oftentimes patients that have a splenectomy, for whatever reason, they might have to get like the pneumovax vaccination against all the different types of streptococcal organisms, some of the ones that cause like meningitis, for instance. So that's some of the big concerns. If it does get removed, generally speaking, the liver and the bone marrow will be able to take over from there. You will be a little bit immunocompromised as a result, though. So that's one thing to keep in mind. If you looked at a cross-section, a histological cross-section of some of the cells that you find in the spleen, you're going to find a couple different types of regions. You're going to find white pulp. White pulp, think lymphocytes. And then red pulp, you're going to think red blood cells and macrophages. So let's talk about the thymus now. So thymus is another important organ within the lymphatic system. The thymus is, in terms of its location, it's going to be just superior to the heart, anterior to the heart. And the thing about the thymus is that it does kind of degrade over time. The major hormones that are going to be released, thymosin, thymopoietin, those are going to be the hormones that help to allow T cells to mature. It's going to be very prominent during fetal development, but over the course of your entire life, the thymus slowly starts to degrade. Once you get really old, you basically don't have a thymus anymore at that point. It's effectively going to be replaced by fatty tissues. If you work in the cadaver labs here, a lot of these cadavers are old. They're very old people. There's like a 97-year-old, if I remember correctly, in there. Is that true? Yeah. No thymus, right? Did you ever see a thymus in that? Have you seen a thymus in any of those? I think I asked you that before, didn't I? Yeah, you don't really see thymuses, or thymusi, I don't know what the plural for thymus is, but you don't really see a thymus in an older person. That's one of the reasons why older people are going to be more susceptible to certain types of infections, right? Like viral infections in particular. Think about like influenza. Who are the people who are very affected by influenza, that are disproportionately affected? Very young and also very old. The older you get, the harder time you have in fighting off things like viral infections. One thing to keep in mind. But in terms of its function, think T cell maturation. That's where T cells go to mature. Also, don't think of it as being something that directly fights antigens, because T cells are not going to be directly associated with fighting off antigens. We're going to talk about it a little bit later. But these are the major hormones. So you have thymopoietin, thymosin, and thymulin. These are going to be the major ones secreted. Let's talk about malts. So malts are going to be mucosal-associated lymphoid tissues. Mucosal, it's going to be found in mucosal membranes. Now, they're going to be diffuse, so you're going to find them throughout like the inner layers of a lumen, for instance. So these are going to be called Peyer's patches. And we're going to talk about Peyer's patches when we get into the cell-mediated immune system, because these are a good example of how like dendritic cells, which are antigen-presenting cells, can communicate with T-cell lymphocytes to be able to mount an immunological reaction depending on the presence of antigens within the GI tract. So this would be like within a GI tract, and it's not labeled here, but this little fella here with the little fingers hanging off of him, that's a dendritic cell. Dendritic cells, they kind of look like dendrites, but they got those little projections. Those projections scour the environment for antigens. And once they come across an antigen, that's when they start presenting those to like T-cell lymphocytes to be able to mount an immunological reaction. But you can find them in different areas. Peyer's patches, that's in the GI. You find them in lymphatic organs like tonsils, for instance. Here's an image here that shows different areas. You can find them within the bronchiole. So those are called BALTs, bronchial associated lymphatic tissues. So here's an image of that Peyer's patch. That's that dendritic cell I was telling you about. It's got that finger that goes all the way out into the lumen, and it's able to detect the presence of certain types of antigens that might be resulting from, like an infectious agent of some sort. Once it does that, once it recognizes the antigen, it's going to take that antigen, it's going to present it to a T cell. I'm going to show you that whole process a little bit later. But you have a bunch of T cells right here. Once that dendritic cell gets that antigen, it just right there presents it to T cells, Helper T cells are going to be able to activate B cells, so B cells can now start turning into plasma cells to secrete immunoglobulins, and then T cells can directly kill. Well, not directly. If it's a helper T cell, it's going to activate macrophages to kill, so it does kind of like it recruits them to do their dirty work. Let's put it that way. So that's Peyer's patches. That's found in malts. Let's do a brief review of our leukocytes. We're going to go through our granulocytes, and then we're going to go through our agranulocytes. And let's watch just a very brief video here. I don't know if I showed you guys this video, but that's a neutrophil. That's a neutrophil following like it's like a diplococcus. That's a bacteria, diplococcus. Shoving the red blood cells aside. And eventually it finally gets to it. There you go. And there you went ahead and phagocytosed a little diplococcus. So, kind of cool. That video a lot. They're kind of cute, in my opinion. Anyways, so let's talk about neutrophils real quick. So neutrophils, they do a lot of different things. If you recall from our leukocyte discussion, we're just going to review the effects of these different cells. So they can phagocytose, just like what we watched just now. It was phagocytosing a diplococcus bacteria. They're going to be able to release reactive oxygen species. One example is hydrogen peroxide. That's an ROS. What those do is that they help to basically compromise the phospholipid bilayer of the cell, as well as other cellular components. But mostly it's going to be compromising the phospholipid bilayer of bacteria. It can also interfere with DNA and DNA synthesis. You get degranulation. Lots of different compounds can get released from those granules. Elastase is one good example of that. And then there's also going to be neutrophil extracellular traps. When the neutrophil explodes, it's going to release a bunch of DNA. DNA is going to be negatively charged. There's going to be a bunch of histones that are associated with that. Those histones and the DNA bind and stick onto bacteria and basically causes the bacteria to just clump up, and then they can subsequently get phagocytosed by like macrophages, for example. So here's a neutrophil undergoing phagocytosis. It's phagocytosing Bacillus anthracis. That's the causative agent of anthrax. So let's talk about parasitism real briefly. If you guys haven't followed Medical Talks yet, this was a clinical vignette that I saw on Medical Talks, I think about a year and a half ago. And so I include it in any lecture that I talk about eosinophils and parasites. And this is getting really freaking annoying. Jesus Christ. All right. So this is a really fun clinical vignette. This dude visits his family in Mexico, and while he was in Mexico, he eats fresh watercress. Who here has ever eaten fresh watercress? I have. Like when my family used to go camping and whatnot, we actually found a bunch of watercress, and it's really quite delicious. But the problem is, if you eat it raw, you also run the risk of maybe getting a parasite. So eventually, this guy started to, he was displaying symptoms of pallor, aka anemia. And then this is the dead giveaway right here, eosinophil count. His eosinophil count was grossly heightened, 1,400 cells versus the reference range, 0 to 400. So when they did the ERCP as well as ultrasound, they were finding biliary ductal dilation. So your bile duct, right? So your bile gets siphoned into your gallbladder, eat a fatty meal, gets released. And so if you have dilation of your bile duct, that's probably indicating that you probably have some sort of obstruction going on. And so they did an ERCP, and this is what they found. So this is the duodenum. The duodenum is where you have bile getting released into your GI tract. And this thing right here, that's not supposed to be there. So there's different types of flukes. The most common is going to be the liver fluke. And this is a liver fluke. And effectively what it does, it likes to hang out in the duodenum. It likes to consume things like bile, for instance. It also likes to barf, apparently. anyone think it's kind of cute? No? No one thinks it's kind of cute? I think it's, even though it's kind of gross, I think it's still, it's kind of cute. Little feller. So anyways, when you see a liver fluke or you see like helminths or anything like that, the class of drugs that we use, I refer to them as bendy drugs. So triclobendazole would be a good example of that. Albendazole. When you see bend in it, you want to think bendy worms. You think like helminths. You're thinking Tinea solium, Tinea saginata. Those are tapeworms. You're thinking like nematodes or liver flukes. And also, you're going to see an increase in eosinophil counts. These are tapeworms right here. Tapeworms hanging out within the GI tract. Tapeworms in particular are kind of gross because tapeworms can come from two different sources, major sources. They can come from mostly pigs as well as beef. So pig tapeworm, that's Tinea solium. Beef tapeworm is Tinea saginata. And they're basically obligate parasites, meaning that they're not able to actually digest their own food. And so when they get into your GI tract, usually you swallow an egg. That's how they get inside. They have to latch on to the inside of your GI tract. And basically what they're doing is they're able to absorb the nutrients from the food that you digest. That's why back in the day, they used to sell tapeworm eggs as a weight loss regimen. If you look up images of like 19th century weight loss regimen, tapeworms, they used to sell them to women and stuff if they wanted to lose weight. I mean, I would recommend other ways of losing weight. The tapeworm is not the best idea, particularly because sometimes tapeworms can also result in things like obstruction if they get bad enough. The one that's really concerning for obstruction would be Ascaris lumbricoides. That's a really nasty one. If you want to watch a really good video that will like repulse you for the rest of your life, watch GI extraction of Ascaris lumbricoides and do it before you eat a pasta dinner and then show it to your friends so that they can all have their appetites ruined. So eosinophils, long story short, eosinophils are going to be directly associated with parasitic type infections. Basophils. Basophils are going to be very, very sparse. You're not really find too many basophils hanging out unless you have an allergic reaction of some sort. Basophils are going to be implicated in the release of histamine, which helps to, it helps the inflammatory process. So vasodilation, aka increased vascular permeability, blood flow to infectious tissues, etc. And then monocytes. Monocytes are pretty big. They're going to be about 5 times or so the size of a red blood cell. The other ones are usually about 3 times the size of a red blood cell, like neutrophils, basophils, eosinophils. They can differentiate. So a monocyte can turn into a macrophage. It can also turn into a dendritic cell. Remember those dendritic cells with the little finger-like projections? They're all going to be derived from monocytes. And then mast cells are kind of interesting. Mast cells, these are going to be right here in the lineage. These are your myeloid progenitor cells and then your lymphoid progenitors. If you remember from our leukocyte discussion, lymphoid turns into all of your lymphocytes as well as natural killer cells. And then myeloid produce all the other cells, one of which is going to be mast cells. And mast cells also release histamine. They also release heparin. But the big thing about these guys is that they remain embedded within tissue. So they kind of stay fixed within different types of tissues. All right, so let's do our quizzes for chapter 21. Any questions before we do quizzes? Okay, rock and roll. Go ahead and log in. We do a head count. Why is this? Are you guys having a hard time logging in? What's going on? You're kidding me. That is not good. Hold on a second. Everyone's having that issue? Everyone. This is weird. Hold on a second. Let me end this. Let me see what's going on here. Let's try that a different way. Let's go. Let's see if this works. Okay, let me see if there's something that happened here. No. Okay, let's try that one more time, okay? Anyone having issues now? Still not working? Waiting for the host to start. Okay. I guess. All right, so it's starting. Oh my gosh, that's weird. That's just, I have never seen that before. You guys looks like you were all logged in, so. Okay. Awesome. Good, good, good. Pretty straightforward question. Just know that whatever excess fluid gets basically siphoned off into the lymphatic system. Oh, awesome. I'm glad to see that most of you guys got that right. That's awesome. Yeah, so if your capillary hydrostatic pressure is high, capillary oncotic pressure low. It's going to be if you have reduced albumin levels in your blood. So, yeah, that's when you would see edema. So, good. And it looks like most of you guys got that correct, which is great. Okay. What is IFOP? What does that stand for? Interstitial fluid osmotic pressure. Awesome. Which is determined by, it'll be determined by the presence of proteins. Okay. So what's the most important protein that we're going to be dealing with when it comes to these types of pressures? Albumin. Awesome. Where do you find albumin mostly in a healthy person? In the blood or within the interstitium? In the blood? Someone say blood? Yeah, so you'll find albumin in the blood. So your interstitial fluid osmotic pressure is usually about 0. You shouldn't really have much albumin within the interstitial space. If you did, that would probably be due to like histamine. You might have an allergic reaction. You might have damage. Maybe like if you were a burn, if you got severe burn and then you had damage to those capillary beds, you might all of a sudden start getting a fluid shift due to like albumin moving into the interstitial space. So generally speaking, it's very low, if not 0, your IFOP. So Most of you guys got it right, so that's fantastic. All right. So lymphatic capillaries, you're only going to find, well, you're going to find in like all of your tissues, except for bone, bone marrow, and teeth. You're going to find primary lymphatic organs within the bone marrow. That's because that's where you have B cells, T cell lymphocytes being produced, right? So that's going to be like the actual organs that help to produce those types of cells. But in terms of the capillaries themselves, the capillaries that actually collect that excess amount of fluid, remember when capillary hydrostatic pressure is higher than capillary osmotic pressure, that 10% difference, that's going to be due to that's going to be collected into the capillaries. And you're going to find those capillary beds everywhere except for these three organs right here. Okay? Make sure you guys know the difference between all that. What's lacrimal? You guys know what that is? Yeah, the lacrimal glands are your tear glands. Right? So if you're lacrimating, that means you're crying. You might have gotten broken up with on Valentine's Day. So that's your lacrimals. Adipocytes, those are fat cells, and lacteals, those are the capillary beds within your GI tract that collects fatty lipids from your whatever you consume. Awesome. Good job, guys. What organ does that? Spleen. Excellent. Good. Stage 3 and 4. So stage 3 is going to be your more local lymph nodes, the lymph nodes closer to the origin of the cancer. And then stage 4 is when you start getting lymphatic involvement in other areas of the body, so further away from that the localized areas. And then that's when you also get metastasis during stage 4. A couple more. And again, it looks like most of you guys got this one correct, which is fantastic. Which is the one that's like mostly involved in infections? Palatine, yeah, palatine tonsils. Cervical lymph nodes. That's those would be lymph nodes in your neck. One more, and then we'll move on to part 2. Lymphatic tissues found in the lymph nodes. So MALTs are mucosal associated lymphatic tissues. So mucosal membranes. That's what you're thinking of here. So you find MALTs, especially in the GI tract, but you can find variants of MALTs in other areas too. You can find them in your bronchioles. You can find them in your like other respiratory epithelial layers as well. So you're thinking mostly lymphatic tissues found in your GI tract. That's what MALTs are. So mucosal associated lymphoid tissues. Not found in the spleen. That's where you find like red and white pulp. That's going to be within the spleen. So, right on. Moving forward. Cool. Good job on that, guys. Let's go ahead and get into chapter 21, part 2. You got first place. Ariana Lee, congratulations. You're rocking it. All right. So give me 2 seconds. All right, I just posted this like before I got here, so hope you guys were able to download it. So chapter 21, part 2 is going to be a little bit more involved. There's more stuff going on here. And by a little bit, I mean a lot of it. It's quite a load of information. So we're going to be mostly focusing on immunology. So part 1, that was more like capillary beds, the flow of lymph, kind of what's going on in your entire body when it comes to like lymph nodes and those types of tissues and organs. But in the second part, we're going to be talking about immunology. So let's watch a little tiny video on Bubble Boy. There's a lot of videos of Bubble Boy, including documentaries. I'll talk to you about them in a second here.
Unfortunately, complications occurred and a transplant was performed for my son, February 1980.
Small in the world, David was the boy of the bubble. Though his life was far too short, he put a very human face on a rare and virtually unknown class of diseases.
I've had occasions disorder, and when trying to explain to someone what it is their child has, they remind that person the story of David the Bubble Boy, and that person understands clearly what it is their child has.
For David's family, though, there were some daunting struggles.
One of the things that I know that I missed was communication with families. Children suffer from the same disorder. It is essential for survival, for coping, that you meet other families who understand exactly what it is you're going through, have the same feelings, and the same fears, and the same anxiety.
So super sad. Kid, David only lived until he was about 12 years old. I think that's when he actually had the procedure done, and unfortunately it didn't work. So nowadays, however, SIDS, our technology has advanced quite a bit. Kids with SIDS can receive bone marrow transplants, and it has a much higher rate of success nowadays. David, unfortunately, that was like during the early days of those types of procedures. So very sad. So let's talk about the immune system. So when we talk about the immune system, there's going to be 2 major branches of the immune system. There's going to be your innate immunity, which is going to be basically non-specific, okay? And then there's also going to be the adaptive immune system, and that's going to be specific resistance. So when you hear innate, think non-specific. If you hear adaptive, you're thinking specific, like your body's adapting to a specific type of organism, or maybe it's an something that might result in an allergy. We're going to talk about all the different types of antigens later on, but in terms of your innate system, you have first and second lines of defense. So first line of defense, think about barriers, think about walls, right? So you're thinking skin. That's going to be one of the major first lines of defense against microbes and foreign invaders. Mucosal membranes are also going to be associated with that. You're thinking skin, mucosal membranes. Think about the skin being, or mucosal membranes being skin within your body. Those mucosal membranes are also going to secrete different types of compounds that are going to be able to fight off infection. One in particular is going to be lysozymes. Lysozyme is an enzyme that's going to be secreted by your tears as well as your saliva, salivary glands. And lysozymes basically break down the peptidoglycan cell wall in bacteria. So it's kind of like one way that it kind of works similar to penicillins. Penicillins target the same structures. Lysozymes also target those structures as well. And then normal microbiota. We all have tons of bacteria living on us, both on our skin as well as in our GI tract. What are the two areas in your body that are completely sterile, that do not have any bacteria in there? You guys know off the top of your head? Urine is actually not true. I used to think that as well, and it was commonly thought that urine was sterile. But it's actually not. There's always going to be a little bit of bacteria in your urine. What other two areas are sterile, like no bacteria? We just talked about one major system over the past couple chapters. What would that be? Huh? Lymph? Is that what you said? Well, lymph is always going to be receiving like stuff from all different parts of the body. Like there's going to be bacteria in your lymph, and your lymph is really going to be trying to identify the bacteria that's pathogenic, right? But blood is going to be one area. If you have bacteria, or not just bacteria, also fungus in your blood, we call that sepsis, right? If it's specifically bacteria, that's called bacteremia. But if you're septic, that means you have infectious agents in your blood. The other area would be your cerebral spinal fluid. So the fluid that you find in your central nervous system. So brain, everything surrounding your brain, as well as down your spinal column throughout the meninges, right? In that subarachnoid area. So those are the two areas that should not ever have bacteria. If you have bacteria or viruses or fungus in your meninges, we call that meningitis. And that, especially if it's bacteria, can be extremely dangerous. People die of meningitis sometimes within 24 hours. So very scary stuff. But normal microbiota is going to be found throughout your body, skin, as well as your GI tract. You have lots of bacteria, and a lot of that bacteria is good. It's part of your normal microbiota. So if you have dysbiosis, which means you have an imbalance of your bacteria, then you can see, organisms that used to be good turning into infectious agents. So have you guys ever heard of C. diff diarrhea? C. diff. You know what C. diff stands for? Clostridium difficile. And difficile, it's very difficult to treat. So a person with C. diff diarrhea, it usually results from a patient who took antibiotics. And then the antibiotics killed a lot of the good bacteria. And C. diff naturally occurs within our GI. C. diff all of a sudden becomes like overgrown and starts like becoming pathogenic. And that's when you get C. diff diarrhea. Yeah, then difficult to treat because it arises from antibiotics. You guys know what the gold standard treatment for C. diff diarrhea is? Fecal transplant. You guys ever heard of a fecal transplant before? I haven't talked to you about that in this class, have I? So fecal transplant. GI doc, when I was doing my internal medicine rotation, told me how he does it. He tells his patient to ask someone he cares about in his life, maybe a family member, maybe a close friend, and he has them get a blender that they don't care about throwing away. Then he has their family relative or friend defecate in the blender, grind it up, and then they put it into a capsule and they use it as a suppository. And so you're transferring good, normal bacteria from one individual to another individual. I don't know why anybody would want to be a GI doc, but that would be one reason not to be. I know you want to do GI, right? Yeah. Anyways, yeah, GI is, I don't know, it's kind of gross. Something interesting about fecal transplants, too, is that the recipient, there's a lot of studies on that, the recipients of the fecal transplant will actually start getting a lot of the metabolic characteristics of the donor, because a lot of our metabolism is going to be dictated by our gut microflora. Our microbiota actually helps us metabolize, digest food, and things like that. So anyways, that's my GI story. I'm not going to go any further into that. Second line of defense, your leukocytes, especially the ones that can phagocytose. Macrophages, neutrophils, those are going to be really huge. They're nonspecific. They see something pathogenic and they just gobble it up and they kill it. So that's nonspecific. Inflammation. So when you have like histamine release, say for instance your basophils and mast cells start releasing histamine, you get inflammation, right? So you get swelling, redness, you have like blood entering into that area, like white blood cells. So that's going to be the inflammatory process, which helps to kill infectious agents. We already talked about antimicrobial substances. And then when you get to that third line of defense, that's when it becomes adaptive. That's when your body's starting to adapt to specific organisms. You get sick by a virus. Then all of a sudden your adaptive immune system starts developing antibodies or immunoglobulins against that specific virus. That's called the adaptive immune system. We're going to go into great detail about that. And that's going to be involving B cells as well as T cell lymphocytes. Those are the main players. There's also dendritic cells. There's also macrophages that play a role in that, but mostly mediated by B cells and T cells. Bless you. So a person is going to be born with innate immunity. That's your non-specific immunity. You're born with skin, I hope. You're born with leukocytes. You're born with the capability of producing lysozyme. These are things that you just have, okay? So non-specific, however, is something that just develops throughout your entire life. It starts when you're in utero, when you're in your mom's womb. You're starting to get immunoglobulins. That's going to be part of like passive immunity. You're just getting that from your mom. And then when you are a child, you're roaming around on the ground, putting things that don't belong in your mouth, but you do it anyway because you're a baby. That's going to help to start developing your adaptive immune system. Okay, so that's really important, and it just develops throughout your entire life. So first line defenses, we kind of already went over that. Skin and mucosal membranes. Second line defenses, phagocytes, antimicrobial proteins like lysozyme, inflammation, and fever. We're going to talk about fever a little bit later. And then specific adaptive immune defense. That's going to be that third line of defense. It's going to specifically target particular antigens. And we're going to talk about what antigens are. Antigens, have you ever heard that term before? It literally just means antibody generator. That's what an antigen is. And antigens can be multiple different things. It can be proteins, mostly it's going to be proteins, but it can also be things like haptens, which if you know anybody with a nickel allergy, those are haptens. Those can be antigens that mount an immunological reaction. So lots of things can act as antigens. So non-specific, innate, skin, and even like mucosal membranes that can secrete different types of enzymes. Things that are found on your skin, your normal microbiota. You'll find like Staphylococcus epidermidis is on your skin. Sometimes that helps to stave off bacteria. Micrococcus luteus is also on your skin. You have lots of bacteria on your skin, and they compete for nutrients so that the bad bacteria don't harm you or have less of a chance of harming you. So antimicrobial proteins, those are going to be things that are going to be involved in like things like bacteria, viruses, fungi. These, whenever you have something that's released to kill these types of organisms, it's generally going to be non-specific. It's like, oh, that's a fungus. We should probably kill that. So it doesn't know exactly what kind of fungus. It's not something that has memory of. It just knows that it's a foreign invader that doesn't quite belong there. And then you can find that those types of materials being secreted by epithelial cells. Mucosal membranes. The reason why I put emo boy over there is because when you cry, you're releasing lysozyme, and lysozyme is going to help basically attack peptidoglycans, which is kind of a really thick outer wall on your especially gram-positive organisms. You're going to find that in your tears and mucus. And the reason why I put the epithelial layer over here in your respiratory tract is because you have lots of nasty bacteria in your mouth. They're bacteria, the bacteria you find in your mouth, generally speaking, streptococcus organisms. So those would be viridin group strep, strep mutans that causes like tooth decay. Strep pyogenes. You can also find strep pyogenes in your mouth, the one that causes strep throat. Strep pneumoniae is often in a lot of our mouths. So these are all things that you often find in your mouth. Why do they not cause, for instance, pneumonia? Is because you have the mucociliary escalator. It's cilia that helps to flap in one direction and helps to push anything that's pathogenic back out into your oropharynx, so it doesn't go down into your alveoli, causing pneumonia. These are some other things that are considered protective agents. Salt. Your skin, very salty. A lot of bacteria does not like salt. There are certain types of plates, for instance, like if you use when you guys get into microbiology, you'll learn about all the different plates that you can grow bacteria on. One is a mannitol salt agar. It only grows certain types of gram-positives. Gram-negatives generally don't really like salt, so they won't even grow on the plate because salt can act as an antimicrobial. Lysozyme, we talked about that. That breaks down the peptidoglycan cell walls. You also have other things like lactoferrin. Bacteria love iron. Where do you find iron? You find it in your heme, right? There's certain types of plates that you can actually grow bacteria on that grow better on like chocolate agar, which is hemolyzed red blood cells. You can also use sheep blood agar to grow bacteria because certain types of organisms love iron. So if you have lactoferrin, you're depriving the bacteria from iron. We're not going to talk about amps in here. That's going to be more when you guys get into microbiology. And hydrogen peroxide. Peroxidases breaks down hydrogen peroxide, so that can also help to kill bacteria. And then your normal microbiota, right? You have lots of good bacteria in your body. Lots of good bacteria, like for instance, lactobacillus. That's going to be found within the vagina. It helps to basically stave away other organisms. If you have a pH imbalance, oftentimes Candida albicans takes over. That's when you get a quote-unquote yeast infection. That's a Candida infection. That might be due to dysbiosis or an imbalance of pH levels. E. coli, you find that inside your GI. We all have E. coli in our GI tract. They're within the whole family of Enterobacteriaceae. So lots of different type of bacteria within your GI. And they're good. They help to compete for nutrients. They help to fight off other organisms. Good ones that can become bad. Big example, Clostridium difficile, C. diff diarrhea, difficult to treat, right? That's going to be secondary to antibiotic use. If you're taking antibiotics, or when you guys are working in the hospital, generally when a patient comes in with a really nasty infection, say meningitis, say pneumonia, one of those types of infections, you want to treat them with broad spectrum empirical antibiotics. Broad spectrum, meaning it kills a broad number of organisms. Once you find out what organism it is, they do what they call culturing and sensitivity. When you send it off to lab to get cultured, they also do a test where they see what kind of antibiotics can actually be used against that organism. Then when you find out the result, you switch to a narrow spectrum antibiotic. Narrow spectrum kills a narrow percentage of different bacteria. In other words, you're running less of a risk of disrupting your normal gut microbiome. So you don't want to mess with your microbiome. If you do take antibiotics, a good thing to do would be taking probiotics. You guys ever take probiotics before? So generally, like the majority of them are going to be lactobacillus. Lactobacillus is a really good bacteria that you find in your body. It's also used to make like cheeses and things like that. Lactose. Lactobacillus is going to be also one of the major components in probiotics. When you take antibiotics, sometimes it's good to take a probiotic just so you can replenish your gut microbiota. So let's talk about some of the things that help to kill cells. Interferons are going to be a class of like cellular communication molecules that help to stimulate different types of activities. So basically what interferons do, they effectively interfere with viral cells, or viral particles. If a cell is infected with a virus, you're going to get the release of interferons to help kill the infected cell. There's a couple different interferons, interferon A or interferon alpha. That's going to help to stimulate natural killer cells. We're going to talk about natural killer cells later. Interferon B would help secreted by fibroblasts to help mitigate inflammation. Gamma is going to be involved in macrophages. So you don't need to know all these specific types of interferons, but know that different types of interferons can help to basically reduce inflammation and also to kill infected cells. So let's see, 413. Let's start talking about the complement system, because the complement system is a total pain in the ass, but you guys need to know it. So let's go ahead and start getting into it today. One of the major consequences of the complement system, phagocytosis, so gobbling up organisms. That's going to be done through opsonization. I'll talk to you guys about that later. I included this image here. This is an electron microscope image of an MAC. They call that a membrane attack complex. It's basically a hole in an organism, and that hole compromises the integrity of the organism, so it kills it. That's the one of the consequences of the complement system. Another consequence of the complement system is going to be diapedesis, which is a fancy word for allowing macrophages to walk along the lumen of a blood vessel and then eventually enter into the interstitial space so that it can kill whatever organism is causing an infection. But the complement system involves multiple different pathways, which we will get into. So complement is going to be involving many proteins. There's 30 or more different types of globulins, for instance, that are going to be involved in complement system. Complement proteins specifically are going to be produced by the liver. And there's two major pathways, but there's actually a third one as well. It's called the lectin pathway, which you guys aren't really responsible for that for this class, but we're going to go into it regardless. But the major ones are going to be classical pathway and alternate pathway. The classical pathway is going to be really fast in comparison, and it's going to be much more effective. The thing about the classical pathway is that it does require an antibody. It requires at least 2 antibodies. You get 2 antibodies that bind onto a bacteria, for instance, and then you have complement proteins that bind to those antibodies. And then you have the cascade of the complement system. The alternate pathway is a little bit slower and not as effective, but the good thing is it does not require the presence of antibodies. And then one of the major goals is going to be opsonization. Let's go ahead and watch, maybe, depending on how long this video is. It's way too long. 8 minutes. I would suggest watching that video on your own time, just so you can kind of like refresh yourself on the material. But let's go a little bit further in here. So these are some of the complement proteins. They're numbered, I think, C1 through 9, if I remember correctly. There's lots of different complement proteins. But classical pathway, it requires 2 antibodies. Once you have these 2 antibodies binding onto a bacteria, for instance, they're going to change their configuration and they're going to expose what we call a complement binding site. You find that directly on the actual immunoglobulin itself. Once that happens, then you get the first complement protein binding to those complement binding sites, and it undergoes a cascade of different complement proteins where they change, eventually converging to C3. That's where you have the common pathway of the complement system. But the major goal is, for instance, mast cell degranulation, which releases like histamines, causes inflammation. Opsonization, which I call glorified phagocytosis. But know what opsonization is. Just know that you're gobbling up a bacterium, for instance. And then cytolysis. That's with the membrane attack complex, or MAC. So that's the classical pathway. It's going to be moderated by the presence of immunoglobulins. So you have to have antibodies. The alternate pathway does not need antibodies. You're also going to get the activation of C3. That's going to be kind of like the common pathway. And then you have different complement proteins that do different things. And we're going to go into detail of each of those complement proteins. But you can get histamine release, increased vascular permeability. You get opsonization. And you can also, again, get that MAC, the membrane attack complex formation. So complement, many proteins, C1 through 9. Those are going to be all the different proteins involved. C3 is going to be what's like one of the major things that allows for the full complement cascade to take place. It's going to be converted by C3 convertase, which is an enzyme that splits C3. And just keep in mind, complement system is not adaptive immune system. This is all going to be part of the innate immune system. Okay, so it's going to be non-specific. So here's the major goals of complement. These are the major goals. So pore formation. That's that membrane attack complex. So when you hear MAC, you're thinking punching a hole into the bacteria. So now it's going to lyse. It's going to undergo lysis. It's going to be unable to withstand osmotic pressures. Opsonization, I call it glorified phagocytosis. That's not what you'll find in the literature. That's the way I conceptualize it. So I hope that helps you guys. You're basically just gobbling up the bacteria. And then histamine release is going to be another major consequence of complement. And I say that we stop here. And we're going to go into complement in more detail starting Thursday. Have a good one, guys.